organizing this lecture series called Insights, which is innovative, non-traditional healthcare settings in HIV research. And basically the purpose of the lecture series is to provide the space for researchers and community members to come together to hear about and talk about innovative research that's conducted outside of the traditional healthcare setting. So whether they're pharmacies, patients' homes, mobile clinics outside, and really understanding how these spaces can be used to better increase access to medications and engagement in care. The lecture series is funded by the UCSF CFAR, and it's my pleasure and honor to introduce Dr. Katrina Ortblad for her presentation titled Leveraging Private Sector Pharmacies to Expand the Reach of HIV Prevention Services in Kenya. Dr. Ortblad is an implementation scientist and assistant professor at the Fred Hutchinson Cancer Center. Her research seeks to improve equity and health access with differentiated models of HIV service delivery in high prevalence settings. Her ongoing research projects are all in Kenya, including cluster randomized controlled trials, testing different cost sharing models for pharmacy delivery of PrEP and PEP services, which we'll hear about, a pilot study testing an online model of PrEP and PEP service delivery, and a cluster randomized controlled trial testing a model of formalized peer PrEP referral enhanced by HIV self-testing among young women. So without further ado, I would love to invite Dr. Ortblad to take it away.
Sounds great. Well, thank you so much, everyone, for having me here today. And thanks for that kind introduction. I'm really excited today to present to you this collaborative research we've been doing on pharmacy PEP and PrEP delivery in Kenya for the past 6 years in collaboration with Kenyan researchers at the Kenya Medical Research Institute in Japaigo. And I'm also excited to tell you about sort of the remaining research agenda and find opportunities for collaboration. So as this audience is probably well aware, in Africa, HIV incidence is high and barriers to PrEP access remain. In most African countries, PrEP, which is often a donated public commodity, is primarily delivered at public clinics. And here, client barriers to access include stigma associated with visiting HIV clinics when individuals are not living with HIV, limited hours of clinic operation, and long wait times and travel distances to these clinics. To help overcome barriers to clinic-delivered PrEP services, differentiated models of service delivery are needed. In an era of declining PEPFAR funding, getting PrEP into private pharmacies could help leverage the private sector to sustain African countries' HIV response. In Kenya, the Ministry of Health, in its 2017 5-year PrEP scale-up plan, identified pharmacies as one of several target delivery points and implementation research on pharmacy-delivered PrEP services as high priority. Private pharmacies are a promising setting for PrEP delivery for a number of reasons. First, in many low and middle-income countries, individuals first visit private pharmacies for their healthcare needs. Private pharmacies are also well-suited to address both urgent needs like STI treatment, as well as preventive care needs like blood pressure testing. It's also very common that individuals purchase services at private pharmacies that are offered for free at public clinics, like contraception. Additionally, in Kenya, there are over 5,000 licensed private pharmacies distributed throughout the country, which you can see on the map on the right there. And these are overseen by a regulatory board, and they have annual renewal and continuing professional development requirements. In collaboration with Dr. Elizabeth Bukusi's team at the Kenya Medical Research Institute and Dr. Kenneth Ngure's team at the Jomo Kenyatta University of Agriculture and Technology, we have been conducting implementation research to developing and testing a model of pharmacy-based PrEP delivery in Kenya for the past 5 years. This research has included formative qualitative research, stakeholder engagement, pilot studies, which we'll present here today, as well as a hybrid cluster randomized control trial that is ongoing that will create evidence that can inform implementation and scale up. Back in January 2020, we developed with Kenyan stakeholders from regulatory and professional boards a care pathway for pharmacy-delivered PrEP services that was informed by formative qualitative research. Briefly, I want to talk about 3 key challenges that arose related to delivering PrEP according to the national guidelines in the setting, and the solutions that we built consensus around for testing this model in research studies. So the first challenge was PrEP prescribing. So pharmacy providers in Kenya legally are not allowed to prescribe antiretrovirals. So what we did is that we took a model of pharmacy-based PrEP delivery that's ongoing at the Kelly Ross Pharmacy here in Seattle, where pharmacy providers utilize a prescribing checklist to identify clients that are unlikely to have any medical conditions that may contraindicate PrEP safety, like history of liver or kidney disease. And then if individuals meet the criteria on the checklist, the pharmacy provider is legally allowed to prescribe PrEP with remote clinician oversight. And then if individuals don't meet the criteria on the checklist, they are referred to public clinics for care by clinicians. So we took this prescribing checklist that is being utilized at the Kelly Ross model of pharmacy PrEP delivery, and we adapted it for the Kenyan setting and got special permission from the Kenya Ministry of Health for research purposes only to use this prescribing checklist in pilot studies to allow pharmacy providers to deliver PrEP services. The other challenge was HIV testing. So technically, pharmacy providers in Kenya were not allowed to conduct HIV testing unless they completed a 2-week-long government-sponsored HIV testing course, which basically none of them have. A side note is that almost all pharmacy providers in Kenya are delivering HIV testing services, but all of this is pretty much happening unofficially without any proper training. And if you ask these pharmacy providers about what happens when an individual tests positive, they will often tell you that they tell clients the test doesn't work and tell them to go seek services elsewhere. And now, while pharmacy providers are not technically legally allowed to provide HIV testing, they are allowed to provide provider-assisted HIV self-testing. So for purposes of this pilot study, while self-testing is not officially advised for PrEP and PEP initiation in Kenya, we got special permission from the Kenya Ministry of Health to use provider-assisted HIV self-testing to initiate clients on PrEP services at these private pharmacies. And then the last challenge was commodity procurement. So as mentioned, PrEP commodities are often sort of government commodities in Kenya. So able to have the private pharmacies get access to these public commodities, we used a hub and spoke model where we paired private pharmacies that were participating in our research studies with nearby public clinics. And then the pharmacies received public commodities from those clinics, which they dispensed, recorded, and then those dispensing records were reported back to the clinics and counted towards those clinics' PrEP dispensing records. And then here you can see on the right the actual prescribing checklist that we used in our pilot study. And the different components of it including the behavioral risk assessment, medical safety assessment, confirmation of HIV status using the testing methods we described, and record of PrEP dispensing. And as mentioned, this PrEP prescribing checklist was based on the one-step PrEP program that's ongoing at the Kelly Ross Pharmacy in Seattle. We then pilot tested this model of pharmacy-based PrEP delivery in 2 different pilot studies, which I'll describe on the next slide. But to participate in these pilot studies, first of all, they took place in both central Kenya, so the greater Thika area, as well as western Kenya, so the greater Kisumu area. To be eligible, the pharmacies had to have a private room, they had to be licensed, and they had to have a licensed full-time provider that agreed to participate in our training for the pilot study. Additionally, for pharmacy clients to be eligible, they had to be 18 years or older and meet the criteria on the prescribing checklist previously described. To recruit these pharmacy clients, we used posters that we stationed around these pharmacies. We also trained the pharmacy providers to ask clients that were purchasing services indicative of HIV risk, like emergency contraception or condoms, or sexual performance enhancing drugs, if they might be interested in PrEP services. And then there was also a lot of word of mouth referral that took place. And then, as previously mentioned, the commodities where we received free drugs and HIV tests from the Kenya Ministry of Health using the hub and spoke model. Our primary outcomes were PrEP initiation and PrEP continuation, so assessment of any PrEP refills, and then we also measured a number of implementation outcomes. Here we describe the 2 different pilot studies that we conducted. The first was an NIMH R34, and it was a small pilot study at 4 different pharmacies. We delivered oral PrEP services to individuals 18 years and older that met the criteria on the checklist. As described, we delivered provider-assisted oral fluid HIV self-testing, and we charged clients a fee of 300 Kenyan shillings, which is roughly $3, for each pharmacy PrEP visit to compensate pharmacy providers for their time and effort delivering these services. And we ran this study for 12 months. We then additionally received funding from the Bill and Melinda Gates Foundation to extend and expand this pilot study. So we expanded the pilot to 12 pharmacies in both the Kisumu and Kiambu County areas. We additionally added PEP services to the model because we found that a lot of clients were coming in for services like emergency contraception and might actually be better PEP versus PrEP candidates. In a handful of pharmacies, we also added STI testing as a strategy to bring clients into the clinic and provide comprehensive sexual health services. We switched from oral fluid to blood-based HIV self-testing. We dropped the fee for the client fee for pharmacy-delivered PrEP and PEP services. And this really was motivated to provide evidence for PEPFAR, who doesn't allow clients to pay for services donated by the American government. And we ran this pilot study for 6 months. In this next slide, you can see pharmacy-based PrEP delivery in action. So here's some photos of the pharmacy providers that participated in this research study with us. And you can also see the posters that we had stationed around these various pharmacies. And we got permission from all these pharmacy providers to use these photos for purposes of presentations like this. Here you can see the number of clients that enrolled in each of the pilot studies. So you can see that PrEP initiation was high among those we found eligible for PrEP services. So in the original pilot study, we screened almost 600 clients, found 500 preliminary eligible for PrEP services, and roughly 60% of these initiated PrEP. In the pilot extension study, when we dropped the fee for PrEP services, we found almost 700 clients that were preliminary eligible for PrEP services, and 95% of these initiated PrEP. And what was striking in both pilot studies is that almost all clients that initiated PrEP in these private pharmacy settings had never previously used PrEP. We then wanted to understand the reach of clients we then wanted to understand the types of clients that we reached with pharmacy-delivered PrEP services in our pilot studies. And we found that roughly 50% of clients that initiated PrEP in these pilots were male and under 25 years. Roughly 3 in 4 clients were unmarried, so the majority were unmarried. And some of the most common behaviors associated with HIV risk were having a partner of unknown HIV status, having multiple sexual partners, and inconsistent condom use. We were then interested in how the demographics of the clients that we reached in our pilot studies compared with clients that are engaged in traditional PrEP services in Kenya. So those are PrEP services delivered through public clinics, specifically HIV clinics, maternal and child health clinics, and family planning clinics. So we compared the demographics of clients in our pilot studies with those from various PrEP implementation studies that had taken place in sort of the different settings, public clinic settings that I just described. And we found that the clients that we reached at private pharmacies tended to be younger. Most of them tended to be, or a greater percentage of them tended to be unmarried compared to those that are accessing PrEP services in public clinics. And then when we looked at their behaviors associated with HIV risk, we also found that clients reached with the private pharmacy model tend to have a greater percentage of participants, tend to have a greater percentage of partners of unknown HIV status and multiple sexual partners compared to clients engaged in PrEP services at public clinics. And we also tended to have a much lower percentage of of participants who had partners living with HIV in the private pharmacy setting versus the public clinic setting. So this sort of helps demonstrate that we appear to be reaching sort of a different population with great PrEP need in these private pharmacy settings versus those traditional clinic-based models of PrEP delivery. We then evaluated what PrEP continuation looked like at the private pharmacy settings. And in the original pilot study, we found where we charged clients a fee of 300 Kenyan shillings for each refill visit, we found that any continuation was around 55%. And the pilot extension, when we dropped that fee, PrEP continuation was around 72%. When we looked at different subgroups of interest, we found that men over 25 years had the best PrEP continuation, women under 25 years had the worst PrEP continuation, and overall clients greater than 25 years had better outcomes than those under 25 years with pharmacy-delivered PrEP services. We then wanted to compare how these rates of PrEP continuation compared at the private pharmacies compared to rates of PrEP continuation at public clinics in Kenya. So again, we compared our findings to those from the the implementation studies that I previously described. So the partner scale-up study, which looked at PrEP implementation in HIV clinics, the Jalinde, which is a large implementation study that took place in Kenya, which also looked at PrEP implementation at public clinics. And then the PREA studies, which looked at PrEP implementation among women and adolescent girls and young women and maternal and child health and family planning clinics. And here you can see the PrEP continuation at 1 month and 3 months was comparable with the other implementation studies and exceeded continuation rates, especially those observed in maternal and child health and family planning clinics. We then also wanted to, in the pilot extension study, as I had mentioned, we had added PEP to understand how PEP could help clients transition from transition into PrEP services and be sort of a demand generation strategy for PrEP. And we found that PEP was also in great demand at these private pharmacies. So of all clients screened, we identified 171 this is in the pilot extension study, that were preliminary eligible for PEP versus PrEP services, which means we had 3 questions that assessed whether or not they had different types of HIV exposures in the past 72 hours that would make them PEP eligible clients. And of clients determined preliminary eligible for PEP, 95% of them ended up initiating PEP services at the pharmacies. Among those 162 clients that initiated PEP, roughly 40% of them returned to the pharmacy for a follow-up visit and tested HIV negative, and roughly 1 in 5 of them were dispensed PrEP and transitioned to PrEP services. We also conducted a number of assessments to assess acceptability of pharmacy PrEP services among clients and providers engaged in our research studies. And we found that these services were largely acceptable. So, almost over 90% of clients and providers agreed or strongly agreed with different statements that assessed different core components to the theoretical framework of acceptability, such as burden, perceived effectiveness, effective attitude. And you can see some quotes here that sort of reinforce that clients found pharmacy delivered PrEP services highly acceptable. One client said, "I like that it is easily accessible and that the process is instant." Another one said, "It is close to where I live and there is privacy." And another one said, "It's easier to get PrEP here than at a hospital." Additionally, pharmacy providers also liked delivering these services. They said, "Clients are open and this gives me an easy time to deliver PrEP. And this will make the community that I live near, and this will make the community that live near a pharmacy know about the prevention measures that they can take to prevent the spread of HIV." And we're also conducting a number of qualitative research around this model that I'm not going to present here today. In addition to measuring acceptability, we also measured the fidelity of pharmacy-delivered PrEP services in the first pilot study. And this assessment was led by Victor Molo, which is one of the project directors at the Kenya Medical Research Institute, who's been working on this project since the beginning. And to assess fidelity, we used standardized patient actors. So we trained these actors on 4 different potential client types, which you can see here listed on the left. And overall, we found that the pharmacy-delivered PrEP services among providers participating in our pilot study delivered PrEP with high fidelity. And if you want to learn more about this analysis, you can find a paper that Victor published in J-AIDS last year. Additionally, we are in the process of conducting a number of unit cost analyses to determine the cost of delivering PEP and PrEP services in the private pharmacy setting. But we also, using survey data, we're able to assess willingness to pay for pharmacy PrEP services among clients and willingness to provide PrEP services among providers. And we found that the vast majority of clients, both in the model where they had to pay and they did not have to pay, said that they would be willing to pay something for pharmacy delivered PrEP services. In the model where they had to pay 300 Kenyan shillings, the client said they'd be willing to pay 400 Kenyan shillings for each visit. And the model where they paid nothing, among those willing to pay, they said they would pay 300 Kenyan shillings for each pharmacy PrEP visit. And then when we asked providers said that if they received the commodities for free from the Ministry of Health, the median amount they'd be willing to provide the services for was 200 Kenyan shillings for both oral PrEP and injectable forms of PrEP that might be coming in the future. So we use these willingness to pay findings to inform the payments that we are using in our ongoing cluster randomized control trial. So we currently have a 4-arm, 60-pharmacy cluster randomized control trial that is ongoing in central and western Kenya to provide insights on the value add of delivering PrEP and PEP services to private pharmacies and costs. So this 4-arm cluster randomized control trial is testing 3 different models of pharmacy-delivered PrEP and PEP services. These are all kind of different cost-sharing models of pharmacy-delivered PrEP and PEP services. So in the first arm, the first and the second arm, trained pharmacy providers deliver these services by themselves without any assistance. In arm 1, clients pay the fee to access PEP and PrEP services at the private pharmacies. And we set the fee to 250 Kenyan shillings, sort of based on the findings from the willingness to pay assessments I just presented, and through conversations with both stakeholders and pharmacy providers in Kenya. Then in arm 2, clients pay nothing, and we, the implementers, pay pharmacy providers 250 Kenyan shillings for each pharmacy PrEP and PEP visit that clients have in that setting. In the third arm, we have introduced an HIV testing counselor to the pharmacy to assist with some of the time-consuming steps of pharmacy PrEP and PEP delivery. So from the pilot studies, we found, a lot of pharmacy providers would complain that the counseling and testing steps associated with PEP and PrEP delivery were very time-consuming and hard to deliver, especially during periods of time where the pharmacies were really busy. So to help address that challenge, we stationed sort of a lower cadre worker, so an HIV testing service counselor at the pharmacy to complete the counseling and testing steps, and then pass the client over to the pharmacy provider for medical screening assessment, review of the steps that the HIV testing counselor conducted, and PrEP and PEP dispensing. And in this model, pharmacy providers are only compensated 100 Kenyan shillings for each pharmacy PrEP and PEP visit because they're doing sort of half the amount of work than the providers in the other arms. And then finally, for our control arm, we are conducting what is only allowed per standard of care practice in Kenya at the moment. So at the moment, all pharmacy providers are able to do, as relates to delivery of PEP and PrEP services, is engage in conversations with clients that are purchasing services associated with HIV risk about PEP and PrEP services, and give them a referral slip to nearby public clinics where they can access these services. And for each client that gets referred, we are compensating those pharmacies 100 Kenyan shillings to motivate them to do those referrals. And as mentioned, this 60 pharmacy 4-arm cluster randomized control trial has sort of been a huge undertaking. It's taking place in 6 different counties in western and central Kenya. We have a large team that is working on this. We're conducting this research study in collaboration with JPIGO, which is a large implementing organization in Kenya. And we launched this trial in June. So we're about 50% of the way through our projected implementation. And we just had our second DSMB meeting yesterday. Here's a preview of what sort of aggregated data looks like from this from the study to date. So this is data from June 26th to March 15th. At March 15th, we'd enrolled roughly 1,704 clients into this study, 560 PrEP eligible clients and 1,000 PEP eligible clients. And that you can see that sort of enrollment has been pretty consistent since we have been able to launch all 60 pharmacies. And I'm happy to, answer a number of questions related to this at the end, but this was sort of all I was going to present on this trial to date. So when we think about scaling up pharmacy-delivered PrEP services, there's still a number of barriers that remain that this research team is working to address. First, pharmacy providers' scope of practice. So pharmacy providers in Kenya are still not legally allowed to prescribe PEP and PrEP services. So what we are doing is we've developed a number of training materials, which we utilized to train, the 80+ pharmacy providers that we trained for participation in the cluster randomized control trial on pharmacy-delivered PrEP and PEP services. And we developed these training materials in collaboration with JPIGO, and we're hoping that they can serve as public goods at the end of the research study. We're also engaged in discussions with the Pharmacy and Poisons Board in Kenya, as well as different pharmaceutical associations in Kenya, about incorporating PrEP into different degree programs and continuous professional development programs. And JPIGO is actually leading a lot of that work. Another barrier to implementation of this model at scale is supply chain and financing. So we're also in discussions with the Ministry of Health about adding private pharmacies that meet certain criteria to the Kenya Master Health Facilities list so that they can receive public PrEP and PEP commodities directly versus sort of having to be linked to nearby public clinics. And then we're also working with the Ministry of Health to develop a framework for public-private partnerships. And again, a lot of that framework development work is being led by JAPICO, who has a lot of experience doing those types of collaborations with the Kenya Ministry of Health. And then finally, another sort of barrier to scale up is data sharing and reporting and quality assurance. So to address that challenge, we have been working in collaboration with Mesha Meds, which is a point-of-care sales platform for private pharmacies in Kenya. And we've worked with them to sort of develop an application within their platform where pharmacy providers can complete the prescribing checklist. And then we have sort of electronic records of each pharmacy PrEP and PEP client engaged in the pharmacies in our research study that can also be shared with the Kenya Ministry of Health for speedier reporting. This also sort of helps with inventory management and determining sort of when these pharmacies might need restock of PEP and PrEP supplies. Additionally, we're collaborating with Autoray, which is a health technology NGO, and incorporating artificial intelligence and computer vision reading into this electronic platform so that the AI technology can read photos of HIV self-test results that get uploaded for quality assurance and peace of mind for the Kenya Ministry of Health, who might have concerns about the quality of care that is now taking place in public or in private pharmacy settings outside of traditional public clinics. So in summary, PrEP is not having the maximal impact on HIV incidence, and it's not easily accessible to all those in need. Private pharmacies are a promising delivery channel that could help Kenya sustain its HIV response. There's high interest in this channel from policymakers such as NASCOP, which is the Kenya Ministry of Health, and the World Health Organization, as well as funders like the Global Fund. And pharmacy delivery platforms for PrEP services are being included as part of PrEP scale-up plans. Data from these pilot studies suggests that this model is feasible, that it's in demand, that it reaches PrEP-naive populations at HIV risk and can achieve outcomes comparable to clinic-delivered PrEP services. However, currently there's no playbook on how to operationalize public PrEP services in this new private setting. So our studies are generating some of the first evidence on the model's effectiveness and costs. We're identifying training needs. We're exploring options for procurement, quality assurance, documentation, and reporting that can all help inform scale up of this model. And then finally, Kenya is a great test case for the delivery of pharmacy-based PrEP services in Africa. And if successful in Kenya, this model could be adapted to other countries and repurposed for other interventions. In terms of next steps and potential collaborations, I think that there's an opportunity to develop new implementation strategies to optimize the model for pharmacy providers. So as I mentioned, the time it takes for pharmacy providers to conduct the counseling and the HIV testing still seems to be sort of a rate-limiting step and a barrier to implementation. So there might be opportunities to integrate telehealth platforms into these private pharmacy settings. I think there's also opportunities to facilitate collaboration with the Ministry of Health in terms of better reporting systems, especially if these private pharmacies are delivering public commodities. I also think we need to better understand some of these preliminary findings that we're seeing in the cluster randomized control trial, which is ongoing, where we're actually observing a much higher demand for PEP services than we observed in the pilot extension study, which I think is surprising and was actually sort of, making our PrEP initiation, making us sort of fall behind our anticipated PrEP enrollment targets. So I think we need to kind of better understand what that demand is for PEP services at private pharmacies and figure out new strategies to support the transition from PEP to PrEP services for those that have persistent HIV risk. And then, as I mentioned, I think there's a great opportunity to adapt this pharmacy PrEP model to other platforms and interventions. So this same research team recently completed a pilot study of online PEP and PrEP delivery in the Greater Nairobi area in collaboration with Madawa, which is an online pharmacy that's very popular in Kenya. And the findings from that pilot study we plan on presenting at the AIDS 2024 conference. We also are currently conducting formative research on how we can adapt this model of oral PrEP delivery for long-acting injectable forms of PrEP that are on the horizon but have not yet been approved for use in Kenya. And then we're also trying to identify other opportunities to integrate STI testing services or HPV vaccination into this pharmacy PrEP model. But I think it's really important to figure out proper incentives for pharmacy providers to add on more services, because pharmacy providers are not in the business of delivering free public services. So I think one of the big findings from this research and engaging with them over the past few years is that it's really important to get the incentive structures right, so that they are properly compensated for and incentivized to deliver the services that we're asking them to, or that we're training them on. I think there's also opportunities to adapt this model of pharmacy delivered PrEP services that's happening in Kenya to other settings. So we're in some conversations with some Ugandan researchers to think about how the Kenyan model could be adapted for Uganda. I also know there's some work happening to adapt this model for the Nigeria setting. And then finally, I think there's opportunity to collaborate with modelers who might be interested in using some of this pharmacy PrEP, some of this data from our pharmacy PrEP research to inform different PrEP scale-up scenarios. So before we get into the Q&A, and I think we actually ended this presentation earlier than I anticipated. I have a habit of talking too quickly, so apologies there. But this should hopefully leave lots of room for great discussion. There's a number of individuals I need to thank. I need to thank all my collaborators on the pharmacy PrEP team. This is obviously a 60 pharmacy cluster randomized controlled trial in 6 different counties is obviously a gigantic undertaking. And so I need to thank Dr. Kenneth Ingare and Elizabeth Bakusi, my Kenyan co-PIs on this research, as well as Dr. Daniel Were, who's leading the team at Chapago, Stephanie Roach, who's an excellent staff scientist working on my team at the Fred Hutch, Dr. Victor Amolo and Catherine Kim Tiddis, who are the project directors for the Kenyan research teams, and Patricia Ongwen, who's leading some of the operations for the Chapago team. And then obviously I want to thank all the participating pharmacy providers and clients, research assistants, and Kenyan stakeholders that we've engaged with over the years. And at the bottom, you can see a photo of the Pharm Prep research team from our retreat last year in Mombasa. So thank you so much, and I look forward to all your questions.
Thank you so much, Rod. That's really exciting research. And I can't wait to hear more about the results of the cluster randomized controlled trial that you have ongoing right now. That sounds really exciting. While people are getting their questions together, maybe I can just start with a few questions. I was actually just wondering if you have any theories on why there's a higher demand for PEP versus PrEP. I thought that was really interesting.
Yeah, so the much higher demand for PEP is actually also what we saw in the online model of PrEP delivery that we did in the Greater Nairobi region. So I think by the end of that pilot study, which went on for a year, we had delivered PEP services to over 1,000 clients and PrEP services to under 200 clients. And so I think it's a combination of both. I think people are a lot more familiar with PEP. PEP has been around for like a decade. And so people know of PEP in a way that they're not always as familiar with PrEP. So I think that's sort of one theory as to like why we're seeing such higher PEP versus PrEP uptake. And then I think also, I think the big thing is it's often sort of hard to predict when you might be at risk of HIV exposure. And already in these private pharmacy settings, I think one of the things we were really struck by when we first started doing research in these settings is, you talk to these pharmacy providers and they say on the weekends they'll dispense 40 emergency contraception to 40 young women every Monday Sunday and Monday. So I think you have sort of a lot of people that they themselves might not even perceive themselves as being HIV risk, and then have an exposure and sort of come and want to take action. So those are some theories that are being developed, but it's one of the things that we're definitely hoping to explore further through planned qualitative research.
That's great. And that's great that there's knowledge around PEP that they can access. Sarah, I see your hand up.
Thanks so much. And this is really an amazing set of studies. I mean, such amazing work over such a sustained period of time. Thank you. I was wondering about the switch you said in some of the pilot work, you switched from the oral fluid HIV-ST to a blood-based HIV-ST. And I was wondering why, because I know we've done some work in Kenya with men who are fishermen, and they're always complaining about the blood-based tests. So, and like, it's mostly those are like finger prick tests, and they always talk about like, I hate to be pricked. So I was wondering why that change.
Yeah, great question. So, I mean, I think just to take a step back, I think when we first started working in collaboration with the Kenya Ministry of Health and other stakeholders on the development of this model in Kenya to sort of get up and running, the point that actually ended up being sort of the most controversial was how we were going to deliver HIV testing services at the pharmacies. It wasn't about prescribing PrEP. It wasn't about getting the commodities. It was how are we going to do the HIV testing at these private pharmacies. So the reason why in the first to the second pilot study, we switched from the oral fluid was to the blood-based was because people still had concerns about the sensitivity and specificity of the oral fluid test compared to the blood-based test, which were perceived as sort of being more accurate, even though they're both very sensitive and specific. Actually, what I didn't talk about is when we moved to the cluster randomized controlled trial, the Kenya Ministry of Health actually wanted us to switch to rapid diagnostic testing. So in the ongoing cluster randomized controlled trial, we are doing rapid diagnostic testing, and we got special permission from the Kenya Ministry of Health to do sort of an abbreviated version of their 2-week-long NASCOP training course, because a lot of these private pharmacies that we're operating in, they're owned and operated by the pharmacy provider who's there every day. So they can't leave their pharmacy for 2 weeks to go complete a 2-week long NASCOP training course. So our pharmacy provider training was 2 days, and we worked in collaboration with JPICO to incorporate, training on rapid diagnostic testing as part of those 2 days. And then we sort of agreed or collaborated with the Ministry of Health to then have these pharmacy providers do some observed HIV testing at HIV clinics to then sort of get a gold stamp that they can do rapid diagnostic testing for support this pharmacy PrEP and PEP service delivery model only. So it's something that is sort of part of the ongoing conversation about how we're going to solve the challenges around HIV testing to get this model up and running at scale. But great question.
Thank you. Can I ask one more?
Yeah.
The other one I was wondering about was PrEP continuation and how you were measuring that and your thoughts about that, because it seemed to me like perhaps you were measuring it by just picking up like the next month's prescription. And I wondered, was that it? Was continuation measured in terms of picking up the meds, or was it being measured in terms of like a self-report, or was there any discussion about taking like a hair sample or any other type of sample to do like an assay to actually check for like concentrations?
Yeah, great question. So, I mean, as we all know, measuring PrEP continuation is very challenging. And also it's hard to also interpret sort of what good continuation is, because people's HIV risk is constantly changing. But what we did in the pilot study is we did just assess it as to whether or not you return to the pharmacy to refill your drugs in the pilot studies. We also, for a subset of clients for both of those pilot studies, we did collect DBS samples and there's just been some delays in actually sort of getting those the PrEP adherence measured in those samples. So we're in the process of doing that right now and should have findings from that soon. For the cluster randomized control trial, we actually switched to a different strategy. So we are not just measuring continuation among those that return to the pharmacy and refilled. We're conducting a brief client survey with everybody that initiated PrEP at the pharmacy, so that we can actually follow up with those who never returned to the pharmacy to understand if maybe they went to a public clinic or they went elsewhere to continue PrEP services. And understand also if maybe their HIV risk changed, so that we can kind of also better determine if discontinuation was appropriate for those that never returned. So that's sort of a change that we're doing in the cluster randomized control trial.
Thank you. That's so interesting.
Thank you so much, Katrina. And I think I just had a random question. What do they cover? Like, how can testing take 2 weeks? The training, I'm like, what do they cover during that? It feels like a unnecessarily long way of covering testing.
Yeah, but it was it turned into this big sort of cadre war, right? So when we were at this stakeholder meeting, there was a number of people from the laboratory laboratory sciences group in Kenya that felt very strongly and felt very protective about who can officially engage in HIV testing services in Kenya. So it's, I think, something that is an ongoing debate in the country.
I'm actually just wondering, when the Kelly Ross checklist that you had for the first study and you made the modifications for the Kenyan setting, how were the labs collected so that, so I'm just trying to think how that communication with the clinic happened to get the lab results to know that patients can get medications at the pharmacy or not.
Yeah, great question. So, already at public clinics in Kenya, most STI testing that's happening is just syndromic management and assessment. So there's no kind of like official STI testing that takes place to be prior to any sort of PrEP dispensing. And additionally, while creatinine testing is recommended, it's often cost prohibitive, even at most public clinics in Kenya. And because, potential for sort of like liver complications while on PrEP is so low, it's often we got permission to just deliver PEP and PrEP without any of those laboratory testings, because sort of like with the sort of benefit cost ratio was greater to just get these services to clients without the barriers to laboratory testing.
Ah, gotcha. Okay, so it didn't require the approval that people had normal kidney and liver function.
Right, so we're doing no creatinine testing in this pharmacy PrEP model, but what we are doing to help ensure that clients that need that testing get it is that's why in the prescribing checklist, clients that have any history of kidney disease, liver disease, hypertension are being screened out of the model. So pharmacy providers are not legally allowed to dispense PEP and PrEP to those clients. They get referred to public clinics where they can sort of be seen and get the required testing that might be needed for them to initiate on PEP and PrEP services.
And then what about follow-up labs?
Follow-up labs, yeah, so there's no laboratory testing that's taking place in this model in Kenya because honestly there's very little to no laboratory testing that's even taking place at public clinics in Kenya for PEP and PrEP clients due to the resource constraints.
Gotcha. John.
Hi, Katrina. Thanks for that talk. A quick question. I was trying to dig into the sort of provider consult, as you said, that was a rate limiting step and sort of the trying to use telehealth to overcome that. I'm wondering if sort of the breadth and scope of that consult is, I don't do work in Kenya, but is the breadth and consult of that, breadth and scope of that consult takes longer and it's more complex than maybe the US in terms of like, is there any radical way to streamline that process as opposed to just trying to deliver the same information in a different format?
Yeah, that's a great question. And I mean, I think that's one of the things that we're also really trying to kind of understand is like, what is that consultation looking like in practice? So in the original pilot studies, we had a research assistant stationed full time at the pharmacies to help, enroll clients and conduct surveys with clients before and after their visits. I think what ended up happening when the research assistant was stationed full time at the pharmacy, they ended up being asked to help in some ways with PEP and PrEP service delivery. So I think the pharmacy providers we've also found really don't like having people at their pharmacies because they feel like, there's kind of like someone had once said, one of my Kenyan colleagues told us that we were very brave for going into private pharmacy settings. She said, because it's like entering someone's home, right? Each of these private pharmacies kind of operate according to their own rules and have their own culture. And so I think one of the things that we're trying to understand in the ongoing cluster randomized control trial, where we have fully taken all research assistants out of the pharmacies, and we're having pharmacy providers and deliver and initiate clients using this sort of module that we've developed in the point of care online pharmacy PrEP sales point of care platform, Measure Meds, is sort of what is that counseling looking like in practice. So how long is it taking? What is it consisting of? And we plan on conducting time and motion observations at the participating pharmacies where we can kind of get a better sense of that. But we haven't completed that research step yet.
All right, thanks.
So I think I might have talked around your question a little bit, but I agree. And I think there's great opportunities to sort of streamline that step and think outside the box of how it's being conducted. And I think there's things to learn by like maybe seeing the heterogeneity and how the counseling is taking place across these different pharmacies.
Yeah.
So there's a question from Leela in the chat. In the cluster randomized controlled trial, are the pharmacists doing the informed consent process?
Great question. And this caused big headache for us as we were trying to figure out how we can, remove ourselves from these private pharmacies so that we can observe as real life implementation as possible while still getting consent for participants that are getting PrEP in this untraditional setting. So the way we are doing informed consent in the randomized controlled trial is pharmacy providers will screen clients for potential HIV risk. If clients are interested in the delivery of PrEP or PEP services or referral at the private pharmacies, they then hop on the phone with a research assistant, and then we are actually doing informed consent remotely. So the research assistant will enroll the clients and complete informed consent remotely. And then once the informed consent process is complete, we'll pass the individual back to the pharmacy provider to carry on with the prescribing checklist.
Thank you. Katrina, I'm actually just wondering what your thoughts are on if this were to be actually implemented as far as like long-term toxicity, like if there's no way of doing labs. And I specifically asked this because there's a lot of discussion around having PrEP be over the counter, even in the US, and I'm which I'm totally in favor of. And I'm just curious how you all have thought about kind of the longer term impact and possible side effects that may result from people taking PrEP and not being monitored.
Yeah, I mean, I think that's a great question. And I'm not a clinician, but I know that this is sort of how PrEP is being delivered at public clinics. So pretty much at all public clinics in most African countries, I think there's very little laboratory testing that's taking place. And I know that there's a number of researchers, including like Kenneth Mgwanya, who used to be one of my colleagues at the University of Washington, who has looked at sort of biological metrics to understand the safety of PrEP over time, and found that sort of that there's greater benefits for getting clients on PrEP than there are sort of with these like restraints to access that might be associated with expensive laboratory testing in low resource settings. And I also know the WHO is doing a lot of sort of work on understanding this and incorporating that understanding into like guidelines and recommendations on how PrEP services should be delivered in low income settings. I also know this was like, I'm sure you're aware, like a big debate with the RNA testing requirement that came with the delivery of cabotegravir, which I think a lot of people were really surprised by in terms of and concerned about it's the limited access that requirement might have in low resource settings where RNA testing is challenging to deliver. But that is not my area of expertise, but I know there's a lot of researchers that are looking into that.
Yeah, I'm just trying to think for future purposes. Yeah. Great, thank you so much. And if there's no more questions, we can end the session a little early. Thank you so much, Katrina, for your presentation, and looking forward to hearing about all your successes in the near future.
Yeah, and great to meet all of you, and please reach out if you are interested in any future collaborations related to this research. And thanks so much for your time.
Thank you, everyone.